Welcome everybody to this session of NeuroFest. I thank you for joining us today. And it's timely, I think, to discuss this subject. It's much overlooked. And the purpose of today is to consider what we currently know about if race and ethnicity impacts upon equality and access to neurological services. Are certain groups disproportionately underrepresented or underserved by the services, be those statutory, independent sector or third sector, and really to have a think about at the end what we can do about it. So some housekeeping first. There's quite a few of us dialed in, which is absolutely fantastic. So please be on mute, although I do find dog barking in the background entertaining. It does disturb a few people. And please make use of the chat room. You've all had a chat function. You've all had a practice at that. Georgina is going to be moderating this throughout the event. So you all know it's on the right of your screen. And you can enter your question directly into that. And we will be picking up on those after the speakers have finished. Okay. So I am providing you fair warning that after the speakers have finished, we will be having breakout group towards the end, and I want you to consider the two questions. Oh yes, it's on there, which are based on what you've heard. What do we need to do as a sector to ensure we understand and meet the needs of people with neurological conditions, particularly people of colour? And how might your organisation need to adapt? What do you need to do? There are some very good examples already of charities, for example, who have focused. Okay, so first, we've got a fantastic panel today. They're all going to give you an overview of their experience, either of accessing the services, planning the services, or influencing services. So I'm really interested. And so first, over to Andrew to provide us his perspective as Equality and Inclusion Lead at the only hospital trust in the UK dedicated to providing comprehensive neurology, neurosurgery, spinal and pain management services, and that is the NeuroHub, the Walton Centre. So over to you, Andrew.
Hi everybody, Andrew Lynch, Walton Centre. I'm the Equality and Inclusion Lead. Basically what I'm going to do today is just talk to you really about my experience in terms of access and specifically to neurological services for people with neurological conditions from BAME communities. So for me it goes back to the end of 2001 when I went to work for what was then called Neurological Centre. That was a long time ago. It's now called the Brain Charity. Same organisation doing very much the same kind of work, information, support, advice, non-medical for people with neurological conditions, working in the community. So basically what had happened is that the organisation had been running for a number of years, and over that time they had realised that there was very few people from BAME communities coming through the doors looking for their help. So they looked into it and basically spoke to the Walton Centre, spoke to local NHS organisations, and it was a problem really. People were not getting picked up by the system. So we decided to do a logic bit and see whether we could get a project together to actually address this issue. So I worked as part of the project really, and what we did is basically we looked at what the situation was. Very few BAME communities accessing services. So we went out and started to speak to the communities. Now, it was just limited to Liverpool, just because of resources really. And so the approach that we took was based on the communities in Liverpool. Now, I realise fully that Liverpool is a bit different from many other parts of the country. It's not got massive BAME communities like, if you like, Birmingham and London, or even Manchester, but it has got significant communities. So what we've got in Liverpool back then in the early noughties was basically small communities, about 10, 15,000 strong, Somali communities, Yemeni communities, Black British, Caribbean, African, various Asian communities, all relatively small communities, and all relatively self-contained, if you like, not really interacting with each other that much at all, and also quite isolated communities and marginalized in many ways. So when we started to talk to the various communities, what we instantly found was that the issue was not about racism. Very clear, came out very, very early. It was not about racism and not about the fear of racism. It was more about marginalization. It was more about not being mainstreamed. So, not getting the information. So quite often we'd find that communities wouldn't really, so specifically new communities, like, so for instance, refugees and asylum seekers, they weren't even accessing the NHS, in the numbers that you would expect. Contrary to what you might read in the papers, people don't come here to use the NHS. Quite often we found that they weren't aware how to access the NHS. They were coming from countries they never had developed health systems like we've got here, and didn't even realise that they're entitlement half the time. So lack of knowledge about the NHS was quite prevalent in some communities. There was a great lack of knowledge about what a neurological condition was. Big confusions about the overlap between neurological conditions and mental health conditions. Some communities never even recognised that there's a difference. And in the languages of some communities, there's just no recognition of that difference. So there was issues like that. There was also language issues as well. Big barriers about the community not learning and not finding out about what was going on really, and not being able to access because of those kind of issues. So our big barrier that we found really was at primary care. It was not that there was a specific issue about neurological services. It was specifically about primary care, and then the, if you like, referral on to specialised services. And that wasn't just neurological. However, we're looking at neurological, and we were way back then. So what did we do about it? Really? Okay, so Liverpool being a relatively small city, it was possible for us to go out to communities and link with community leaders. Back then, there was still a very strong voluntary sector in the city. Organisations were there and were going strong. This was prior to some of the big hits that the voluntary sector has taken. So talking back then, it was relatively easy to link up to the people who were working on the ground in the various communities, various community leaders, various religious organisations were helping out. So yeah, there's big stigma to be broken down various communities, but there were events that were happening that we could go along with our stand and talk to people. We did some leafleting, but that wasn't the major thing, because we learned very early on that the major thing to get the message across is word of mouth in lots of smaller communities. So having a profile, having a constant profile, people getting to know your face, people being able to approach you, people being able to approach other people in their community who actually know a little bit about neurological conditions because we've spoken to them about it. That slowly built up. So we did start to see an increase, small increase, to be perfectly honest with you, small increase of people coming through, because it was one small project, and it was time limited because it was a lottery project. So in terms of what we did with that sort of legacy, one of the key things we did is we did make strong links with the Walton Centre, training staff about some of the issues that when they do cater for and serve patients from minority ethnic communities, that they are aware of cultural sensitivities, cultural differences, and are happy to cater for that. So that dialogue started. We took people up to the Walton Centre, spoke about these issues, like, you know, conversations and that. So that introduced the community to the Walton Centre and the Walton Centre to the various communities. And that basically through the project that was continuing. Also, there was a recognition that we needed to spread the word in general to various neurological charities, basically, that work needed to be done. And that means educating your own staff and your own volunteers, but also getting out into the community and promoting your services because people don't know about them. So this went from 2001 to 2006, this project. There was a legacy project that went on after that, really, and that was about promoting the need to be competent and confident about diversity and getting out into the communities to actually promote your services and engage with people. I've no idea really how that actually continued on, how successful or not that was, because I moved on then and I went on to work in a predecessor to what is now Health Watch, and that's basically engagement with all service users of health services, and promoting their voices and being a champion for the consumer and for the patient. So basically did that for 9 years or so before I moved on to the Walton Centre. Now, just in general, from my experience of working in Health Watch, it was very clear that, yeah, neurology has got an issue around this, but it is part of a much wider issue of BAME communities being marginalised, not using services, not accessing services, finding it difficult to use services, and the fact that services want to be accessible but struggle to make themselves accessible. So that's across the board. When I came to work in the Walton Centre, much of my work is based around HR and staff side, but I do take responsibility for some of the patient side stuff as well. And yeah, same kind of thing that was prevalent way back when, early 2000s. There still are issues for us, so we still do get some issues around competence of our staff. We do train our staff, but they still make mistakes. So an example might be, we had a lady come to use our service a year ago, and she was a black woman. She had was very cold, and she had a condition which affected the nerves in her face, so she had to wrap her face. So she came with her husband, who happened to be white. When she came to the reception, the person on reception addressed her husband and asked, "Are you her interpreter?" Now, this woman was born in Britain, black British, from Yorkshire, broad Yorkshire accent, and found that quite offensive. Didn't address her, addressed the white person who was with her, and basically it's her husband, and addressed him as an interpreter. That was bad enough, but there was no apology. It was just basically brushed aside, really. So we've used that experience, and we've got that lady's testimony, if you like, about what happened, and we use that in our training. So it's an example that we do actually still need to keep training, and we can't just take it for granted just because we've got some of our information translated and that we've all had our E&D training, that it's all hunky-dory and it's all easy. Sometimes it's quite difficult, but we do prioritize this at the trust. And one of the things we are aware of is that we're still not getting the referrals through from primary care. So, for instance, 97% of our patient cohort are white. Okay, so we serve the whole of Northwest and further. So Northwest, the population, BAME population is around about 12%-ish. Okay, so us seeing only roughly 3% of BAME population, it's a massive shortfall in terms of what we'd expect. The barriers there are not in terms of referral. You know, it's not us, we're not turning people away. It's just that they're not coming to us. So again, it's the old story. People are not getting past primary care. So what happens is you will find that some people are getting picked up later in their condition, and they may end up going to A&E and they get referred onto there, which means basically that there can be the treatment can be more difficult, and the outcomes can be, you know, less effective at times. Fortunately, that's not marked in terms of our patients, but our BAME patients do tend to stay with us a bit longer. So I don't know whether that's because they are coming to us further on within the process of their condition. But these things need to be looked into. And as I say, I think what we need to do going forward is us as a specialist trust need to work more closely with our CCGs, to work with primary care, and to make that link with the voluntary sector, so that we're more proactive as a system working together to actually promote our services. And we do actively have to promote our services to the communities where people are not currently accessing them and where they are feeling isolated. My personal experience is that when we did get people through our service, they were really marginalised. You'll know yourself, just generally, when people access services, neurological services and neurological charities, quite often they're very isolated, become very isolated within the community. But we're talking about people who are from isolated communities quite often, and they're even isolated within that community. So reaching them can be so difficult. That's so we need to be very proactive, and it's a long-term, that's what I found, it's a very long-term kind of problem. So it needs long-term solutions, needs staying power. It means basically, for me, that the approach to it can't just be about initiatives, it can't just be about projects. We've got to find ways to mainstream this within our service, so that we are actually consciously and unconsciously making ourselves accessible all the time, finding ways to do that.
I think, Andrew, that you've made some really, really important points there that I'd really like to pick up later. You know, for when we've heard from Trish as well. I mean,
absolutely,
very